Hi everyone, welcome to ResearchMD.com. My name is Pramil, Cheriyath, and I'm a Program Director in Internal Medicine Residency and Transitional Residency. I teach medical students and residents on a regular basis. I'm also Director of Research, Assistant Professor of Medicine, two large medical schools. We've been doing a series of morning reports so we can look at the cases and learn from it. That's the best way to learn, okay? So we're going to start our morning report today. So let's start.
So, this 42-year-old female presented to the emergency department with increasing fatigue.
That's a complaint.
For the past 2 weeks.
Okay, so we got a 42-year-old female with fatigue. Any case you present, when you hear the presenting complaint, I always ask, what's the first thing I ask? Somebody tell me. Is there an emergency? Is there a big emergency in this patient, somebody with the fatigue? Not that much, right? I don't see any life-threatening. I can have to call surgeon, like operate, those kind of things. So I can take my own sweet time to come up with my diagnosis and all that. So let's talk about when somebody say like fatigue, again, we need to class. First of all, fatigue is kind of like a vague complaint a lot of people comes to, okay? Some people, men say it'd be like tired, and females say more like a depressed and all those kind of things, okay? So when you talk about fatigue, what's the number one thing you have to differentiate is from like sleepiness, okay? So when you talk about so some questions you can always ask, I'll ask, when you watch television, do you go to sleep? Or when you sit in a car, do you fall asleep within an hour? Okay, or after eating a meal within 30 minutes or something, do you go to sleep? Those kind of things kind of help us. It's like a sleep disturbance, very important. Some people, again, fatigue is a victim. The number one thing to make sure to differentiate from sleep. Okay, to make sure it's clearly fatigue, the questions you can ask, like what happens when you do exercise? Okay, and does the fatigue get worse, or you get tired, or I started a day as a good, and as I progressed, I feel more weakness. That is more kind of classic definition of fatigue. Everybody got that? Okay, now the next thing is we need to know, fatigue is an acute fatigue, a subacute fatigue, or is a chronic fatigue. Okay, so we have to know what is the definition for acute fatigue, like give me some numbers.
Less than
6 months?
No, when you say acute fatigue, it's like less than 30 days. Okay, subacute between 30 days, between a 1 month and a 6 month, and if it is more than 6 months, that is like a chronic fatigue. So this person have only fatigue for, like you said, like 2 weeks. Right. So I would put that as more than acute fatigue, right? So let's look at that. The first thing we have to look at the differential diagnosis, right? So what are the differential diagnoses? The best way to do is, when we look at, I'm going to write here, we have to differentiate between acute, subacute, right? Yes. And then we have to say is chronic, right? 1 month, right? 1 to 6 months.
Yes.
And more than 6 months. Everybody got that? Okay. Now let's look at our differential diagnosis we're going to come to. The first thing we have to do, in this patient, we know it's like an acute. So let's look at the organic causes, okay? We'll say organic causes, and we'll say non-organic, okay? Non-organic. So let's look at what are some of the organic causes. Let's start with the endocrinology and metabolic causes, okay? We'll start with endocrine. It's a huge differential. Endocrine, metabolic. What are some causes of endocrine metabolic? Somebody tell me.
Hypothyroid.
Thyroid disease.
Yes.
Right?
Diabetes.
Okay. Number 2, diabetes, okay. What else?
Adrenal insufficiency.
Huh?
Adrenal insufficiency.
Adrenal insufficiency, that's very common. Any kind of pituitary problem, adrenal insufficiency. When you say it's not only hypothyroidism, hyperthyroidism. So let's put in the broad category as thyroid disease, diabetes, is that adrenal insufficiency, right? Adrenal insufficiency. Anything else? Okay, what about renal disease, right? You say like metabolic and all those kind of things, endocrine metabolic renal failure, somebody have liver failure, right? And then what else? Like you say like, hypercalcemia also some of the causes. Say renal failure, right? Renal, liver, abnormal calcium, right? Let's say abnormal calcium. Okay, so we talk about endocrine causes and endocrine metabolic causes. And the number two, then I look at my differential diet. What's the other thing? I'd say like a neoplastic. Okay, that's the other thing, right? Malignancy. Let's say neoplastic, right? Neoplastic, any kind of malignancy can cause us like fatigue, right? And then we talk about the other main thing is what? Hematological causes. We can put it up here. Hematological, right?
Yes.
What are the hematological causes mainly? Like anemia, right? Anemia, that's like, you have to know anemia. Okay, so far we're doing good. We looked at the endocrine causes, we looked at the neoplastic causes, we looked at the hematological causes. Let's look at some infectious causes. What are the infectious causes we have to? Infectious causes.
Can it be tuberculosis?
What?
Tuberculosis.
Tuberculosis. Don't always think tuberculosis only in the other third world countries. Don't make the mistake. Okay, in the United States also, what type of population? People in the prison, incarcerated people, they can have like TB and all that, okay? So don't judge people based on like what. It's good to have their history and all that. I'm just saying like don't automatically judge people and say like if somebody from South America or like, the Far East and don't assume it's always TB. You have to be very careful, okay? What about infective endocarditis?
Yes.
Infective endocarditis. Okay, HIV,
Hepatitis.
right?
Hepatitis.
Very good. What else?
Epstein-Barr, EBV.
Oh yeah, EB virus. This is one of my favorites. A lot of people don't know. It's very common Epstein virus infection, right? It can stay in the system for a long time, make you fatigued and all those kind of things. Epstein virus, don't forget it, okay? And then we can talk about some of the chronic diseases, right? Any kind of chronic disease. Give me some chronic disease. CHF, right?
Yes.
COPD, right?
Yes.
What are the other things we have to say?
Depression.
Depression?
Depression.
Yeah, we'll come back to that. I think we can say it's an organic or non-organic causes, right? That's more like non-organic causes, right? We talk about CHI, we talk about like chronic obstructive disease, right? We talk about multiple sclerosis, right? We can say Parkinson's disease are the other thing very common. Lupus, so many things can have like rheumatoid arthritis, right? Lupus, right? Parkinson, and all those kind of things. So everybody agree that those are the main things we have to think about.
Yes.
And what is the other thing? The other thing is like the pharmacological causes, right? We'll just say like pharmacological causes. What are the pharmacological causes for? What are the pharmacological?
Hypnotic.
What drug? Okay, hypnotic drugs. What else? Even hypertensive drugs can cause it. Okay, and then you can have like antidepressant, right? Alcohol can cause or any drug. Alcohol drug withdrawal or any of those kind of things, right? So hypnotics, very common, right? Hypertensive medication. Okay. What else?
Antidepressants.
Yeah, antidepressants. Okay, what else? Alcohol, drugs, right? Let's put alcohol, drugs. Okay, now we have this another big category up here, non-organic causes. This is the one more like psychogenic, anxiety, somatization, right? Drug addiction and all the idiopathic, and then okay, so we can say, right, psychogenic, right? What else you can say?
Idiopathic as well.
I mean, anxiety, right?
Anxiety,
Depression,
depression, somatization.
somatization.
Malnutrition.
Yeah, I mean, I don't know. I think this is more like an organic kind of like, and I can say like in the malnutrition causes,
Okay.
right? And then what are the causes? Then we can say like idiopathic, right? What is the like? That's a chronic fatigue syndrome. It's another big topic, right?
Okay.
Chronic fatigue syndrome. Again, this is more like an acute situation. It's been going on only for 2 weeks. So remember, all our differential diagnosis, we have to think about it. First, we have to, when you talk about just going to, when you talk about fatigue, to differentiate from what? Somebody said that. Sleep. Okay, so sleep disorder. You ask what kind of questions you can ask? You can ask, are you like after a meal you go to sleep? Watching TV you fall asleep? Or when you drive, you're sitting in the passenger car. Not when you drive, but if you're sitting on the passenger car and you fall asleep, and then within an hour we have to think. And then we put on acute, subacute, and chronic, and then we look at 1 month, 1 to 6 months, and the difference between the numbers we need to know. Okay, so if it is acute, it's less than 1 month, and then you have all this organic. The first you have to look at the organic causes. First one, endocrine, metabolic, you got thyroid, diabetes, and all of this, okay? And then you got neoplastic, any kind of malignancy, and then we talk about hematology, the anemias, they're very common, infection, anything, TB, infective endocarditis, right? HIV, hepatitis, all of that. And again, you got a big chronic disease, which is like CHF, diabetes, COPD, lupus, even thyroid disease, and all of that. Parkinson's disease, SLE, right? And the pharmacological causes, don't forget it, that's why we need to know what medication, hypnotic, hypertensive medicine, alcohol, drug, and all of those kind of causes, right? And then we have other causes like non-organic, psychogenic anxiety, depression, somatization, and finally you got idiopathic causes, chronic fatigue syndrome, a huge topic, nobody knows what exactly causing it. So put them into organic and non-organic. So tell me about this case a little bit more.
Yes. So the patient also complains of having headache and has been exercise intolerant for a while.
Headache, positive. Okay, exercise intolerance.
Yes.
Okay, what else?
And
anything else?
For now, these are the only complaints.
Okay,
no other
let's go to
complaints.
past medical history.
The patient has GERD and diabetes.
Good. And the diabetes. So we know, like, diabetes is like one of the chronic conditions, can cause like a fatigue and all that. Okay. And then anything else? What are the other history we have to say?
The patient has no allergy history.
Okay.
The patient is on PPI and metformin for her medications.
Okay. Now medication's important, right?
Yes.
We already said. What are the medications patient is on?
PPIs and metformin.
Metformin, right? And I don't think at this point we don't know. But they don't cause like fatigue, right? We know that. Okay, metformin, and then
the social history.
Yeah, social history. Tell me.
Patient does not drink alcohol. Does not smoke, but the patient is vegan. Like she has only vegan diet.
Vegan.
And the patient needs to drink at least 5 to 6 cups of coffee per day.
Okay, coffee per day. I think it's kind of important, like one of the causes could be hematological, right?
Yes.
And then anemia, those kind of things, the vegan diet, 5, 6 coffee, we'll come back to that.
Yes.
What else?
Her OBGYN, her menstrual history.
Okay, let's
states
go to the OBGYN history. Okay, what happened to OBGYN?
She has heavy menstrual bleeding. Her cycles are every 2 to 3 weeks.
Menses heavy.
Yes.
Okay.
The cycles are every 2 to 3 weeks.
Yeah.
Irregular, and they last for at least 5 to 7 days.
Okay.
The patient has a very heavy flow. And
why is it important over here? Why is it like heavy menses important in our differential? Because we need to worry about like an anemia kind of causing, right? At this point, we don't know. But at least that kind of make it like a strong possibility. What else?
Past surgical history is not significant.
Okay. Did you take the sexual history?
Yes, the patient is single and not married.
That's it. That's all. The only thing I need to know. They're not single. They're not married. That's my complete sexual history. What's the best way to ask sexual history anyway? Are you going to ask like, what is the best way to ask sexual history? Somebody said people make the mistake all the time. You hear like a medical student or a brand new intern coming in, they can really piss off the patient. So the best thing to do is, I stop right here, okay? I get the, OBGYN history, and I would say, like, let me stop it over here. And then I have to ask you some very personal questions. You don't have to answer if you don't want to, but I just want to give you a warning, because this is the questions we have to ask all the time. It's going to help us to make the diagnosis better. So just don't jump in. Okay, and then you can say, like, what is your partner? Are they male, or are they male or a female? Don't jump in to say, like, you have to be very careful now these days. And then how many times you have sex? Do you have sex with the strangers, or those kind of thing? Or you can say high risk sexual behavior. Okay, why is it important, this patient? Because we already said, like, infectious causes like HIV could be like one of the causes, also like a fatigue kind of thing, right? Sexually transmitted disease also related. Very important, okay? And then psychiatric history. Is that important?
Yes.
Right? And we already talk about our inorganic causes,
Yes.
right? Psychogenic or anxiety, depression, somatization, all that's kind of important. Okay. All right. Now tell me the vital signs.
The patient's blood temperature is 36.1.
Uh-huh.
Blood pressure is 104/60.
Mm-hmm.
Pulse is 78.
Uh-huh.
Respiratory rate is 14.
Mm-hmm.
And saturation is 98%.
98%. Okay. All right, nothing unusual right here, when you look at the vital signs. Okay, now let's go to physical examination. What kind of things we have to look for? Let's start with the before. I'm not even going to, somebody tell me, like, what kind of things you have to look for in the physical examination.
The general appearance.
General appearance, what are we looking for in general appearance?
How the patient is.
How sick the patient is.
Yeah, like, they're like cacti, malignancy could like out of the week and all that. The first thing you have to look at, how do they look? Are they short of breath? Are they like in distress? Or the cachexia is very important in this patient. Okay, let's start with the eye. What are we looking for in the eye?
Paleness, so.
Yeah, pallor, right? Conjunctiva, I look at the
Yes.
pallor and all those kind of
Yes.
things, right? And then what else?
The patient.
What else, like, anything else you have to, I would look at the mouth, or is it anemia, any other causes kind of important. What am I looking for in the neck? Malignancy, right? Lymph node is kind of important, right? And then I would just look at every system is kind of important in this, because you have a huge differential. Malignancy, lungs examination is important.
Yes.
Cardiovascular system is excellent. Abdominal examination is important, all that. So tell me the positive finding here. So if there is pallor?
Yes, there was pallor.
Okay.
The skin also looked pale. On
Pale.
overall general examination.
Mhm.
On cardiac examination, there was 3/6 systolic murmur at the left sternal border.
Mm-hmm.
On examination of her, she had mild spooling of the nails.
Yeah.
And-
Spooning of the nail, like,
Yes.
that comes over here. Don't mix it up. Just,
Yes.
I don't, when you present it, right? Why did you go into jump from, general examination, all of a sudden you come to, cardiac examination, and you jump back to general examination. Don't do that. I don't like it. Okay? So be systematic. When you present to somebody, everything kind of systematic. Okay?
Yes.
All right. So we got a systolic murmur. What else? Abdominal examinations, everything is okay?
Yes.
Did you do a pelvic exam?
No.
Why is that? Is it important?
Yes.
Right? You already said she's having heavy menses,
Yes.
right? And when you do, isn't it important? Let me ask you, is it important to do a pelvic exam? Right?
Yes.
Yeah,
Yes.
no, it's very important, right? But just always, like, if you're a female, or even if you're a female, always get like a chaperone in the room before you examine, ask the patient permission. That if you don't do those, you can get into huge trouble. Okay? If you ask it, anytime you're male or female examination on the genital area, number one, get a chaperone. Doesn't matter you're a female and examining female, I still get a chaperone. Alright, let's look at the labs. What labs are important to us?
CBC.
Okay, somebody tell me what labs important and why should we check it? What labs, then we will say. What labs are important to us?
CBC.
CBC, we need to know. Definitely, like, one of the differential is anemia, right?
Yes.
Okay, infection also can cause, like, WBC is important, right? Agree?
Yes.
And the sodium is important, right? Chronic, so hyponatremia can also cause this, and we have to add that over here. And then potassium, does it cause weakness?
Yes.
Yeah, potassium is important. And then you got metabolic acidosis can cause this problem. Can renal failure cause this problem?
Yes.
Even creatinine
Yes.
weakness and all that. Can diabetes, blood sugar is important, all of that's important. Okay, so tell me the lab values.
Patient's hemoglobin was 6.4.
6.4.
WBC was 4.6.
Hold on 1 second.
It's okay.
I'm writing at the wrong place. So what is the WBC? Start with the WBC.
Okay. 4.6.
4.6.
Hemoglobin is 6.4.
6.4.
Platelets is 262.
262. Okay. So we know there's anemia kind of going on. Everybody agree that?
Yeah.
Yes.
So hemoglobin is 6.4. Okay. And what is the sodium?
141.
Mm-hmm.
Potassium is 4.9.
4.9. Okay.
Chloride was 105.
Uh-huh.
Pica was 23.
Mm-hmm.
BUN was 18.
Yeah.
And creatinine was what?
1.
Yes.
Okay. What about the blood sugar?
120.
120. Okay. So we know this patient already have diabetes, right? Did you
Yes.
say? Blood sugar is 1. What other lab work is important to us? We based on all this differential diagnosis, what else is important?
The iron workup.
Okay, because there is anemia, then iron workup, and tell me the iron workup.
Yes. Serum iron was 9.
Serum iron 9. Okay.
TIBC was 441.
Uh-huh.
Iron saturation was 2%. Ferritin was 4.
Ferritin is 4.
Yes.
Okay. What else important?
MCV, we also did that, was
What is MCV?
70.
70. Okay. Any other labs important?
We
to
did
us?
RDW,
Okay. RDW is what?
was 19.
19. Okay. What else? Any other labs important to us? Or are we going to just jump in and say, this is what I'm going to do? I think it's iron or anything else we need to do. Should we check a TSH? It's
Yes.
common, right?
Yes.
Kind of like, I
Yes.
mean, I would definitely order a TSH. Maybe like an ESR. It's like simple test, kind of remember, to do and all that. We still don't know what's our diagnosis. We have to come up with a diagnosis. ESR, what else? We already talked about calcium level, right? I would check a calcium level also to make sure, we're not missing anything. Any other lab we missing? Anything we should do?
We also did her folate and B12, which were normal.
We said vitamin B12 and folate.
Yes.
Why did we order that? Why did we, we know the MCV is 70, right? And that's another big mistake people make, right? Ordering too many without thinking, right? If the MCV is low, it could be it's very less likely to vitamin B12 folate deficiency. What is that? Like a microcytic, right? Megaloblastic, those kind of picture, right? So be careful. But they checked it, that was okay.
Yes, it was normal.
Should we check a reticulocyte count? Nobody said anything about it. It's
Yeah.
very cheap test, right? It was normal?
It was normal, yes.
What
1.2.
Okay, that's kind of, that's normal. What else? Nobody said about peripheral smear. Somebody with anemia, the biggest mistake people do is anemia, transfuse, don't do investigations. What happens when you transfuse and then try to investigation? Everything is kind of messed up. So every time somebody come with an anemia, my first thing is to make sure, I get a peripheral smear. Send to the lab, a lot of times, I get make a slide and then take it to the lab and I look at myself or ask the lab people, hey, can you help me? That's the best way to learn. Everybody got that?
Yes.
Don't forget it. This patient should have a peripheral smear. Okay, so we did make sure you order the peripheral smear. Very important. A lot of people, I'm not going to blame you what you did today, but next time, I don't want anybody with anemic. I want to see peripheral smear. Okay, remember that. All right. Any other investigation? Any other imaging we need to know?
We did, doctor, we did CT.
Okay, why did you do CT? Is that the best test to do? Somebody tell me. CT? No. What's the best test in this situation?
Ultrasound.
What kind of ultrasound? Maybe like a pelvic ultrasound, right? Uncomfortable maybe for the patient, cheaper, no radiation. And how much a CT scan radiate people? How much?
800 extra.
Yeah. Now, when you talk about CT and the radiation, if the patient asks you, the best way to say is equivalent to x-rays, equivalent to chest x-ray. So it's anywhere, I think last time I heard, anywhere could be 500 to 600 x-ray equivalent, right? Which you can do, and which you could have done it. So use your judgment next time. I've seen this all the time, the ER doctors. What do? They want something done right away. CT is so fast, everybody come to the ER, they automatically get millions of CTs in the United States. So don't make the mistake. So what should we do? Or an ultrasound.
Yes.
Okay? That's the pelvic ultrasound. In this case, what did they do?
We did CT.
What did that show?
It showed large fibroids in the uterus.
Large fibroid. Okay. Does the fibroid bleed? Yep.
Yes.
Got like a lot of blood, so it's very vascular substance and all those kind of things. Okay. All right. So what's our diagnosis? Somebody based on this, what's our diagnosis? Can we say what is our diagnosis? Somebody tell me.
Iron deficiency.
Okay. Let's say like anemia. First, I would say it's an anemia, right? And anemia, iron deficiency. Anemia, iron deficiency.
Blood loss. Chronic blood loss.
Blood loss is there. Okay. So remember, like what test is important to say it's anemia? Tell me. First, you got MCV low. Which one you will put the most important thing? Somebody tell me. We talked about before. What is the most important, like in this test can say this patient have anemia?
Serum iron.
Serum iron, wrong answer.
MCV?
I have said that so many times. MCV, no. What's the most important is ferritin. Okay, if the ferritin level is less than 30, the sensitivity and specificity is almost like close to like 90%. If it is less than 15, also is very high sensitivity and specificity. My friends, don't ever forget it, right? Somebody ever say, what is the best test?
Serum ferritin.
Serum ferritin, less than 30. Say it again.
Serum ferritin.
Serum ferritin less than 30. Okay, just don't jump in. The other thing is not not much important to me, okay? When you can only problem is the ferritin is like, let's say if there's an inflammation, right? And then you can say if there's another chronic disease or chronic inflammation going on, you can say even ferritin is less than 100 is more like diagnostic test. Okay, so we have that. We also why didn't get a reticulocyte count? We just rule out any hemolytic process kind of going on in this patient, right? And then we know this is like anemia, iron deficiency. There is chronic blood loss. So what is the first thing you have to do? How do you treat this? Should we transfuse?
Yes, because...
Okay, this is like, what is the number? Less than 7. We have to it's kind of agreed on. So give some transfusion, blood transfusion, right?
Yes.
Right? So now it's becoming like one more question. What is the drug this patient is on? Somebody tell me what drug this patient was taking.
PPI.
PPI. Why is it important in iron absorption? Is it important in iron absorption? Because PPI, what does it do, PPI? When somebody's on proton pump inhibitor. This patient, a gastroesophageal reflux, a lot of people in the United States taking proton pump inhibitor. Okay. So in order for the iron, when you take, right, it goes into the stomach, it's in the what? Which form?
Ferrous form.
It's in the?
Ferrous form. To be observed.
Yeah, it's actually ferric. It has to convert it into ferrous form. Yeah. Okay? So what happens is what is the normal pH in the stomach? Somebody tell me.
Less than 2?
Less than 2, around 2 to 3 area, right? What happens when you give PPI? More like an alkaline, maybe more neutralized. That's why you decrease the acidity, right? When you decrease the acidity, polymerization is kind of affected. So ferric will not be converted into ferrous, so it will not enter in the cell. So iron level could be low. So remember okay? You have to know that. Okay, so what else we can do to increase the absorption of iron? Let me ask you this. If you give large amount of iron to a patient, right, how much it get absorbed in the body? Give me some numbers. So yeah, if you don't know, if you cannot express a number, that means you don't know the situation. So if I give a person a large number of iron, how much it get absorbed in the system? Give me some numbers. Somebody give me some numbers.
20 mg.
20%?
20%.
20%? Wrong?
30%?
Wrong. Okay, it's very less. Maybe 1 to 2%. It's very hard for body to get absorbed and all this. Okay. So what drug can I give this to increase the absorption? Anything can I do? Convert. We've already said ferric form need to be converted to ferrous to enter into the cell. What can I do? I can give vitamin C, right? And the citrate, those kind of things. Okay. Vitamin C. I'll just give some vitamin C. Vitamin C, and then of course I will give Let me see, I'll give iron first. How much iron we have to give it to him? Right? How much iron we have to give? Somebody say, what is the dosage?
325.
325 milligram 3 times daily, right?
Yes.
325, 20,
3 times daily.
3 times, three
Yeah.
times daily, right? What is the form we usually give?
Ferrous sulfate.
Ferrous sulfate. Let's write that very clear. Ferrous sulfate. Okay? So make sure, then I'll add vitamin C to it, so get absorb more. And what else I would say to this patient? Well, you took a very good history. This patient is a vegan diet, right? That also it's like which is in the non-heme form, right? So it's probably a good idea to give vitamin C, and she's taking 5 to 6 coffee per day. Does it help in the absorption iron? Not really, because coffee, all this phytate and oxalate and all that's kind of affects. So I'll stop drinking coffee here. Okay? Stop drinking coffee. Okay, so what is the number 2 problem in this patient? What is the number 2 problem? You got a fibroid. We need to find the cause, fix the cause. Doesn't help if we give iron, it takes like 6 months to build up, but we need to stop our bleeding. You got a fibroid, right? Uterine fibroid. What are we going to call? We're going to OBGYN, right?
Yes.
Consult, need to take it out. Not like this, you don't have to do it like right away. Kind of, later on and all those kind of things. Okay? So those are the main problem. And then this is like, let's look about this. There's an abnormal right here. So there's a systolic murmur, right? Why is that important? Somebody tell me. Why is it like, I'm hearing a systolic murmur. Should I investigate or not investigate? Somebody tell me. Should I investigate?
Yes.
Why is that? Of course it need to be investigated. Why? Tell me why. Does all systolic murmurs need to be investigated?
No.
No, because most of them is physiological murmur, right? Somebody with the pregnancy and this flow murmur, physiological murmur. If your grade is greater than 2, then you have to investigate. You said this is what is the grade? 3/6. That kind of make me pathological. Okay, if it is grade less than 2, you don't need to investigate. And if it's a pansystolic murmur, you need to investigate. And associated with the shortness of breath, then I will investigate. For an examination purpose, if it's systolic murmur, be careful. It could be a physiological murmur like flow murmur. In this patient, it's what? 3/6. I'll get an echocardiogram. Okay.
Yes.
Everybody understood? Okay. Any other questions about this case? Thank you so much for watching. We'll be back with another case. If you have any comments about the management or any other teaching point you want to make, please put it under comments. It's going to help us to learn. So let's make it a big discussion forum about this case, what kind of things we should have worked up. Thank you so much again. Please subscribe to our channel. It takes a lot of effort from different people to put up presentation, things like that, so we all can learn. Again, thank you from the bottom of my heart. Thank you.